Good evening. My name's Eduardo de Marchena. I'm a professor of medicine and surgery at the University of Miami, and I'm the director of the Structural Heart Disease Training Program and the Miami Valves Conference. And so it's a great pleasure to put on this conference for you this year. We had to change like the rest of the world. We tried to hold off as long as possible. Miami Valves is usually held in January or February. We tried to wait and see if Fauci would let us hold the conference in person, but he disappointed me. And so we are doing it in this virtual manner, but it gives us a chance to be able to have a larger reach to a lot of audience throughout the world. And now it's important to know that we will be doing Miami Valves 2022 in person, and it's going to be February 3rd through the 5th of 2022. And so please mark your calendars for that already. It's going to be at the Marriott Biscayne Bay Hotel in Miami. But right now we're stuck with Miami Valves this way. So this is Miami Valves COVID style, which is this virtual platform. I'm going to show you the kind of reach that we've had. This has been the audience that we've had from the last 3 conferences. And it's important to know that with this Zoom platform, you can have a lot more reach than you would normally have with an in-person conference. So in the future, we may be doing hybrids of this so that other countries can share. But we've had 6 continents, 37 countries, 145 cities with attendees from all over. We have about 600 people that have registered for the conference, the 7-day conference. And so we're expecting a big attendance again tonight. I want to thank our supporters, which are our exhibitors, Medtronic, Edwards Life Science, Chessie, and Abiomed, who decided to sponsor this conference, even though it was a teleconference instead of a regular in-person conference, which we really helped them thank them for helping us with this. There are cases from throughout multiple medical centers in Europe, South America, and multiple in the United States that are going to be showing cases or have shown cases in our conference. We want to thank all those in the hospitals and cath labs from throughout the world for sharing their experience with us. So tonight we have a special privilege of having an evening with Azeem, Latib, and friends. The friends are his panel. So that includes us. Let me just tell you a little bit about Azeem. So Azeem is rapidly becoming a major thought leader in structural heart disease, especially in mitral and tricuspid valve interventions. He started his career in South Africa and obtained his specialization in internal medicine and cardiology at the Brijeshwar Hospital in the University of Cape Town. Thereafter, he trained in interventional cardiology at San Rafael Hospital in Milan, where he worked with Antonio Colombo as a senior interventional cardiologist at San Rafael Hospital and the EMO GVM Centro Cur in Columbus, Italy. He did additional training in valvular interventions at the University of Zurich before coming to the United States. Azeem Latib is currently the section head and director of interventional cardiology, director of structural heart interventions at the Montefiore Medical Center in New York. He has published over 600 manuscripts in peer-reviewed journals, numerous book chapters. His interests and experience lie in complex coronary intervention, structural heart disease, and new device innovation. He is the principal investigator in numerous first-in-man, CE mark, and international multi-center studies. It's a great pleasure to have Azeem with us, a great educator and person. So Azeem, I'm going to stop sharing. I'm going to let you share, and you're on.
Great. Thank you so much for that incredible introduction, Eddie. And I miss coming to Miami for Miami Valves. So you gave me the best news, which means I'm coming to Miami in February next year. You can count on me being there for this great meeting. And, you know, I think this format that you've created in the evening really is testimony and symbolizes what we do in Miami Valves, which is talk about cases, challenge each other, and share our experiences with complex cases. So I really love the format. I'm going to give you a short talk and try and give you an update on emerging technologies for both percutaneous mitral and tricuspid valve repair. I'm not going to talk to you about the clinical need or how many patients have mitral regurgitation or tricuspid regurgitation. I really want to talk about devices. Some of these devices you'll see in the clinical cases, but I think, since most of us on this call are interventionists, we want to know what's the new toy we're going to have in the up and coming years to play with. These are my conflicts of interest. So let's start with mitral. This is the device landscape for mitral currently. Really impressive, how many devices there are in this landscape. I continually update the slide, but there's so many devices. There are a number of these that have been used in humans, and clearly I'm not going to talk about mitral clip. You all know about mitral clip. I think when it comes to edge-to-edge repair, PASCAL is rapidly growing as an important contender and an important option for our patients with both degenerative and functional mitral regurgitation. We have some data now from early feasibility studies showing really excellent data for MR reduction. The device is now commercially available in Europe, and in the United States, we're doing the CLASP 2D 2F trial where we're randomizing patients with DMR and FMR to either PASCAL or mitral clip, with some interesting also nested registries for patients that potentially are not great candidates for a clip that could be treated with PASCAL. As we go into mitral and tricuspid, we continue to try and adopt what we've learned from surgeons and reproduce a lot of the surgical techniques. So one of the surgical techniques is annuloplasty. There are a number of devices. I've just shown you the picture here. I'm not going to go through all of them of how you could do annuloplasty. You could do it indirectly using the coronary sinus to modify the annulus and decrease annular dimensions. This does have some limitations because the coronary sinus is not always at the level of the mitral annulus and maybe above or below it. Then you can also do this directly by really impacting the annulus directly. And there are a number of devices that do this. They get anchored to the annulus either via sutures or screws. And most of them are really above the annulus and will cinch the annulus down and decrease dimensions. I think as these devices become more available, we will see this. We will see combination therapies happening where we combine edge-to-edge with an annuloplasty to try and optimize our long-term outcomes. These are cases mostly done in Europe. You can see, using the carillon with the mitral clip. We, a number of years ago, combined mitral clip with Cardioband. There are people who have combined millipede and mitral clip. And here's a case of Cardioband with neocords in a patient with degenerative MR and a dilated annulus. These are what are the new devices I think we're going to see in repair. We are going to see a whole lot of devices for transeptal caudal repair. We know there are two devices that are available for transapical repair, but I think we all know that we want a transeptal device. So here are 4 companies doing it in slightly different ways: Pipeline, CardioMac, CoreMedic, and Neocord, all trying to really treat that prolapse segment with artificial cords and anchor either to a papillary muscle or to the apex. 3 of these devices allow you to actually adjust the length of your anchors on a beating heart, and so really get the reduction you need. Another sort of area which I think is interesting, and we all see this, those of us who do transcatheter edge-to-edge repair, is that there are patients who don't have good posterior leaflets, either very tethered, very small posterior leaflets. So there are a number of companies figuring out how do we enhance or replace the posterior leaflets. So Polaris is a company that's already doing first-in-man. They can use this implant made from nitinol ePTFE. Half Moon has also started their first-in-man here in the United States with a posterior leaflet baffle that creates a coaptation surface for the anterior leaflet. I won't talk too much about transcatheter mitral valve implantation because I know you've discussed it before in Miami Valves, but this has been an interesting area where there have been lots of valves and lots of devices that are no longer present. There are valves that can be implanted transapically or transeptally, but the numbers still remain quite small and we need more clinical experience. The one thing that valves do give us when they can be implanted is reproducible reduction in mitral regurgitation. I mean, you really do get rid of the MR. You just look at the data here from some of these devices, Tiara, Intrepid, or Tendyne, the MR reduction, which is durable with time, is really impressive. But finding the patients is a challenge. Yeah, even in a paper we have under submission right now shows that probably 2 out of 3 patients who we screen for TMVR device are excluded because of anatomical or clinical reasons. So, even though TEER is really now the standard of care, I want you to keep your eyes open because we do need a toolbox. We will see annuloplasty devices, we will see transeptal cords, and we will see posterior leaflet enhancement devices. So let's talk about tricuspid. I mean, this is really my area of interest. I think this is, extremely interesting. There are a number of devices, and I think here again, you see how we've tried to reproduce what our surgical colleagues do. So either we've tried to reproduce suture annuloplasty, or ring annuloplasty, or improve coaptation, or do valve replacement. If you look at the TriValve registry, which is the largest real-world registry of what we're doing, most devices that we using actually are mitral clip and TEER devices, again, edge-to-edge devices, just because they've been so widely available. So they probably now, I said you 2,000, they're probably well over 3,000 cases being done with TriClip. There's now a dedicated device that's commercially available in Europe, where this device is being used commercially for patients with functional and degenerative TR. We have pretty good clinical real world data showing that we can reduce TR. There's still a lot of residual TR though, but this was an initial experience. And we do have a CE mark study, the Triluminate study, that really illuminates us in how to use this device. So it tells us that we probably need multiple clips in most of our patients. You can see 80% of patients needed 2 or more clips. The most common target is the anteroseptal commissure, followed by the posteroseptal. We can reduce TR, but not in all patients. There's still a lot of residual TR. And even though we have modest reductions in TR, we can make patients feel better. But most importantly, what it shows us, this data, is that using edge-to-edge, like on the mitral, on the tricuspid, is very safe. The Triluminate study is underway in the United States, and this will hopefully allow us to have this device available in the United States, the randomized trial comparing the TriClip device versus medical therapy. And PASCAL has also now become available for the tricuspid. This is commercially available in Europe, also showing good reductions in TR. Initially with the PASCAL, the original PASCAL device, but nowadays most cases are done with the PASCAL ACE device, which is a smaller, thinner device with a thinner spacer. Currently, we do have the large CLASP 2 TR trial, which is underway in United States. Again, a randomized study, very similar design to the Triluminate, randomizing patients to either PASCAL or optimal medical therapy. But it's really important to remember, for those of you who want to do tricuspid leaflet edge-to-edge devices, it's really patient selection is really important. And I would suggest you read this article that we wrote with House Lighter, who was the first author in Neurointervention, that really, even though it's in 2018, I don't think this has changed very much. If you want to start doing these, if you choose an ideal candidate, that's the best place to start. And that's how you get reproducible results. I mean, we just did a case today, me and Mei Chow, my partner, with an ideal candidate, and the procedure took about an hour. So if in the right candidates and the right patients, this is becoming a rapidly reproducible procedure with great outcomes. We also will see annuloplasty devices on the right side. Cardioband is the one that's been used the most. It has a CE mark and available in Europe. There is a US early feasibility study that's been completed, again, showing reductions in TR, but a lot of residual TR. But once again, patients do feel better. And I think we will see this device again in a more advanced format that will allow the procedure to be even easier. The area where I remain the most excited is transcatheter tricuspid valve replacement. And I really think this is going to be I'm going to predict the dominant therapy on the right side. I think it's going to beat edge to edge. There are a number of devices that are becoming available. Here you see a summary of most of them. Navigate used to be the device with the most clinical experience, but it required mostly transatrial access because it was such a large device. But a number of different valves. But right now, the valve with the most clinical experience with over 100 patients treated is the Evoque valve, which I'll show you in a moment, but also the Intrepid is being used in tricuspid, the Lux from China, TriCares, and the TriSol device, which is a really unique device that's coming out of Israel that allows you to have some closing volume. So here's a patient treated with Evoque by us. This is a completely transcatheter device with 28 French delivery system. And these are the kind of results you see. Here's a patient with torrential TR, and this is the kind of results you see at the end of the case. I mean, really no TR. In procedures that are have been pretty reproducible and done in a very short time. Here you see the data from the early feasibility study, compassionate use data with Evoque, 25 patients treated. Now remember, this is the first time Evoque gets used in a tricuspid valve, 92% success rate. Look at the delivery system insertion to removal time, 68 minutes, with procedures as short as 37 minutes. So those of you on the panel or on the call who've done tricuspid clipping, you know how long your first cases took. This is pretty impressive. Safety profile in these initial patients look good, but there's a lot we still need to learn about valves. We need to learn about durability. We need to learn about whether there'll be thrombus on these leaflets, and also what the risk of conduction disturbances are going to be with the valve. There is a TriSense study underway. An early feasibility study has been finished, and the TriSense pivotal study has started. This is a randomized 2-to-1 randomized study where patients will be randomized either to the Evoque valve or optimal medical therapy, which, remember, for the right side is essentially a diuretic, and Sushil Kodali is the PI of that. We also will be doing, or have started doing, an Intrepid tricuspid transfemoral program led by Vinny and myself. We've treated the first patients in this study, and we'll try to treat 15 patients to learn how this valve can be used on the right side. I have to say, thus far, the results have been very promising. We've seen great outcomes in the first patients treated, and I think we'll see more on Intrepid tricuspid. There are some other unique options as well that people are trying, and such as treating the IVC and SVC, or putting spacers into the tricuspid valve, or creating really this conduit between the SVC and IVC. I think there is a place for these kinds of technologies, possibly in more advanced patients. And so, we will see some of that too. I've shown you a lot of devices, but you could probably divide them into 3 large groups: annuloplasty, leaflet repair, and replacement. And this is a slide I stole from Sushil. I think we have to start realizing that not all these devices are completely applicable in all patients, and some patients will do better with one device versus another. And so we will need algorithms on how we treat these patients. This is the algorithm we use to decide which clinical study to put our patients into for tricuspid. We're lucky enough to have a number of clinical studies here in Monty, so we can be very selective. But I think based on the anatomy, the coaptation gap, the RV function, annular size, you can really then decide which device your patient will be suited to. So Eddie, I'm going to stop there. Hopefully I've given you and the attendees really a great overview of what are the emerging technologies in mitral tricuspid, and I'm really happy to answer any questions you may have. You're on mute, Eddie.
I said, fabulous. You did more than I expected in the time period that you had. So, and it is incredible, the wide variety of devices that are potentially coming down the pipe. I know of some that you didn't even get to mention, and so there's many other possibilities. Unlike the mitral valve, where I always thought repair was better, I also don't think that, I think that tricuspid repair may not be better. And I'm starting to understand that. So before I make any comments, I want to introduce my fabulous panel. And so joining us today is Maini. Maini is internationally renowned also for his work on the mitral valve. He's the program director of Florida Atlantic University in cardiology. He's the national Florida medical director for cardiology for Tenet Healthcare in Delray Beach, Florida. He also has the major honor for me of the man that taught me how to do mitral clip. Then following that is Fabio de Brito. He's becoming a very, very well-known interventional cardiologist in the Americas and throughout the world. He's involved in multiple structural heart disease trials. He's an interventional cardiologist from Sao Paulo Medical School in Sao Paulo, Brazil. Also, Christian Witzke. He's the director of structural heart disease program and the fellowship training program in cardiology at the Einstein Medical Center in Philadelphia. Brian O'Neill, who once was an interventional fellow of ours and then has grown to greatness in becoming a very well-known interventionalist and a structural heart disease expert. He presently is an interventional cardiologist at Henry Ford Hospital and the director of interventional cardiology research in Detroit, Michigan. And then also will be joining us, Carlos just joined us, Carlos Alfonso is an associate professor of clinical medicine. He's a cardiology fellowship program director and the director of advanced coronary and CTO interventions at the University of Miami, also an expert structuralist. Mauricio Cohen, the professor of medicine and director of the cardiac catheterization laboratories at the University of Miami, will also be joining us shortly. As always, we have Sergio Perez. Sergio is the Eberhard Grube International Structural Heart Disease Fellow at the University of Miami, and he's done a great job. The Dr. Joe Lamelas, who's the head of our cardiothoracic surgery program and one of the world's experts in minimally invasive valve work, will also be joining us after he's done with the case that he has. So I'm going to be moving the cases around perhaps in different order depending on who can join us when they join us. But first thing I want to do is any comments or questions for Azeem from my panel?
They're speechless.
No, they were left speechless. Yeah.
Well, I do have a question. Can you hear me?
Yes.
So something that puzzled me about the tricuspid arena, and I don't do tricuspid clip yet, but I'm being puzzled by the interaction of the pacemakers. And whenever I get a phone call and can we do something about this tricuspid valve, there's always a lead, or 30-40% of time there is a lead around. And I'm wondering what is, you do this for as a main thing. So what is your thing with these leads? What do you do with them?
Yeah, that's a great question, Christian. Leads are across the valve are the most challenging part of tricuspid, without a doubt. I think leads and probably evaluating RV function are the two parts where we're still learning so much. So, the one thing with leads is most times it's actually not the lead causing the TR, or it's not a lead holding the posterior leaflet or septal leaflet open. It may have caused TR in the beginning, but it's not the main cause of TR when we see the patient. So when we deal with leads, we spend a lot of time interrogating on TE, trying to understand where the lead is. If it's sitting in a commissure, okay, out of the way, that's kind of the best position for it, maybe in the posterior septal commissure. And then we'll do clipping irrespective of the lead. If it's sitting in the middle or it's holding a septal leaflet open, which is unfortunately can happen, those are the more challenging ones where, for example, doing edge-to-edge repair is very difficult, if not impossible. One, from being able to grasp, but also two, from an imaging point of view. Those patients, though, some of them may be a candidate for a valve, especially a valve like Intrepid that doesn't grab onto the leaflets or the chordae, but pushes everything to the side, right? We've also, in many cases, have had to remove the lead in order to have a patient become eligible for a procedure. Now, the problem is, I can tell you, whenever you remove a lead in someone with severe TR, the TR doesn't get better. So you're not removing the lead to make the TR better. You're removing the lead so that you can hope the patient get into a clinical study, because now the lead's not in the way of the device and not causing any image artifacts. But it remains, basically, you've heard me say, it remains a huge challenge.
Very good. I'm gonna go on to the first case, and then we'll come back to some of these points. And so Bridge is also an expert in tricuspid imaging and tricuspid repair, and he's gonna be showing us a case. Bridge?
Thank you, Eddie, and appreciate the kind introduction. Let me share my. All right. Okay. So Eddie, thank you very much for having me on the webinar today. And my task today is to share a case. And this was a very interesting case that we had a little while ago. So as you know, every time we talk about valvular heart disease and catheter-based interventions, we're talking about 80, 90, and in South Florida, 100-year-old patients, pretty much have both their legs in the grave, so to speak. So I thought, let's bring a 30-year-old patient that you would say, what are you talking about, Bridge? You're doing a tricuspid clip on a 30-year-old patient. So this 30-year-old patient came to us with severe tricuspid regurgitation. He had tricuspid valve repair in 2012. And at that point in time, when they repaired it, this patient unfortunately had endocarditis, and they repaired the leaflet and did not replace, because he was pretty much in his late teens at that point in time. And then now presented to us with painless abdominal distension, early satiety, reduced functional capacity. He was getting lightheaded with exertion, and he had a transthoracic echo, which showed severe tricuspid regurgitation. So the question was, in a 30-year-old patient, and it took us more than a year and a half to decide what to do with this guy, was because neither the patient nor his referring cardiologist wanted him to go through another sternotomy. And then at this point in time, they knew for sure this was going to be a replacement. So imagine a 30-year-old patient winding up with a prosthetic tricuspid valve, and then give this person, I call kid, another 10, 12 years, and now you got a valve in a 40, 42-year-old. So what you are doing is, this is a death sentence for this person. So after a lot of going back and forth between the patient, the referring cardiologist, our team, we said, you know what, we will get permission. And interestingly, the third-party payer agreed for us to go ahead and do a tricuspid clip on this patient. And this is how it went. So I'm sorry, but I don't know why it's going so rapidly. The patient's heart rate was not this fast. So you can see here, patient indeed has severe tricuspid regurgitation. One of the things that we have realized as we are looking more at TR, that all TRs we thought initially were felt to be functional tricuspid regurgitation. There's a lot of degenerative tricuspid regurgitation as well. You have prolapses, you have a lot of other things that these patients have. So adequate interrogation of these leaflets is extremely important. And I'm not going to go into tricuspid imaging, but with the advent of 3D and explaining, biplaning, depending on which vendor you're using, so you got to use these technologies and imaging techniques to be able to decide where exactly is the leak. Now, in this case, you can see the tips of the anterior and posterior leaflets. There's fibrotic scarring. So this is not functional tricuspid regurgitation. This patient actually has degenerative tricuspid regurgitation with right now, having an element of right-sided heart failure, if you will. So for people who are not used to looking at the tricuspid valve, that would be the anterior leaflet, that would be the posterior leaflet. So depending on where your X-plane is or biplane is, if you put your biplane on the anterior leaflet versus the posterior leaflet, on the opposite side, you'll see the septal leaflet and the commensurate anterior posterior leaflet. This is, in my mind, for all the tricuspid clippings I've done, this is the best view to be able to grasp leaflets, apart from transgastric view, or for that matter, if you have a good 3D image, that works out well as well. So in this case, you can see the X-plane is going smack in the middle, and on the opposite side, you can see where the gap is, if you will. Now, again, as I said, 3D is extremely important. And I apologize again, I'm not sure why this is going so fast. So you can see the septal leaflet is here, posterior would be here, and anterior would be up front. Thank God it slowed down a little bit. So in this case, you can see the clip coming. So as I was alluding to, that would be your anterior leaflet, your posterior leaflet, septal. And in this case, you can see the X-plane is almost in the middle, but edging more towards the posterior side. Now, one of the things which is important is that we've learned over the last few years is that you grab the septal leaflet and try and bring the septal to the anterior and then septal to the posterior. Rarely would you have to bring anterior and posterior together. Now, there are instances where you would have to do that. But the traditional thing now has become is that you go septal anterior, septal posterior. You would want to go ahead and do septal anterior first. And the reason for doing the septal anterior first would be is because your TE probe is sitting in the esophagus. If you put the septal posterior clip on first, you're going to have so much artifact from the posterior clip that it'll become difficult for you to see the anterior leaflet and septal leaflet, and therefore a difficult clipping procedure, if you will. So using these X-planes to your benefit is extremely important. And so the way I look at it is that in your mid-esophageal view, about 60 degrees would be like your intercommissural view, and the X-plane view would be like the LVOT view that we would use for our mitral clipping. So you would see the clip in a straight line in the 64 degrees in the mid-esophageal view, versus on the orthogonal view, you would see the clip arms nicely. So in this case, as you can see here in our biplane view, we can see the clip arms nicely. We can see the anterior leaflet and the septal leaflet. And again, you see here, if I hope the resolution is good enough, the septal leaflet is up here and the anterior leaflet is down here. So the question comes is you almost have to come slightly turned. And I'm not going to show you 1,000 images that we took for this patient, but just to give you an idea that to bring the clip arms up in such a fashion that you're able to grasp them appropriately. If we were to drop the grippers in this view, you're not going to grab onto the septal leaflet. So after lots of trial and error and so on and so forth, and again, this would be the 0 degrees view. And a lot of times when we use 0 degree view for grasping when imaging is difficult, and in the same thing for tricuspid clipping as well, you can see here that we are using the 0 degree view here as well. And you can see here that the leaflet is kind of buckling on itself, and this would not lend itself to a good grasp. So there's a lot of patience that is required in being able to do tricuspid clipping and to be able to get a good result. Now, we were able to grasp the septal and anterior leaflet. Now we are going in, now wanting to grasp the septal and posterior leaflet. You can see the previous clip is right here. There's the other clip. And now we got both clips on. And that's what we were left behind with. So essentially, a couple of hours or 3 hours it took us to take care of this patient. The patient did extremely well. As you saw from the date here, let me see what the date was. I've forgotten the date. Is almost 2 years ago. This patient has completely been asymptomatic. All his abdominal bloating, early satiety, lightheadedness that he was feeling has gone away. His right side has not enlarged at all. He's got trace to mild tricuspid regurgitation, no evidence of increased right ventricular systolic pressures or anything like that. So the hope here in this 30-year-old patient was to buy him time. If we could buy him X number of years, at some point in time, if and when he gets a replacement, he would hopefully be a decade, 15 years older than what he was a couple of years ago. and to be able to provide him as long of a lifespan as we could. So these catheter-based technologies could down the line be used for patients like this as well, even though this is not a regular run-of-the-mill tricuspid regurgitation patient that we would see in our office and offer them catheter-based edge-to-edge repair. Thank you very much.
Beautiful case. So, you know, you illustrate well the difficulty in imaging here. And I'm wondering whether the greatest difficulty is really learning how to image well for the tricuspid valve more than anything else. What are your comments on?
Right. I mean, Eddie, I cannot emphasize that more. If we think understanding the mitral valve was difficult, and as to how anal almost you have to be to understand the echo imaging part for the anterior and posterior mitral leaflet, for the tricuspid tri-leaflet valve, it is even more important. And for us to understand not only the leaflet size, you know, which one is bigger, the understanding the subcardial apparatus, how much space do you have left behind underneath the leaflet? Again, remember, the right ventricle is not that deep, you know, so you could very easily go and hurt, you know, and come out of the right ventricle because it's not a left ventricle. You got a long way to go down. So all those things become extremely important. Are you going to create tricuspid stenosis too? Is also a concern. So while, you know, we have gone on to say septal anterior and then septal posterior, and as I was alluding to, is that we are now realizing that a lot of these tricuspids are degenerated as well. So to be able to identify them, to be able to see them, and again, our biggest issue is TE is standard of care, but TE is on the opposite side to where the tricuspid valve is. So TE is beautiful for the mitral valve. It's not really so good for the tricuspid valve. So we do need better imaging. ICE is showing some advances. You know, as you know, I've been an ICE buff for a long time, and some of the new 3D ICE probes, especially with Nuvera, you know, they're commercial. I haven't seen them trying to sell their device right now, but things like that I think are going to be important. And even more so important would also be CT imaging. So pre-op CT imaging, understanding a lot of those things, doing good TE, doing good ICE, pre-procedurally understanding where you're going to put the clip on, I think is going to be very important for tricuspid edge-to-edge repair.
Azeem, any comments on that? And also, have you had any experience? Because I actually was hoping that Bridge would go on to the 3D TE ICE, because I know he's done a lot of work with it. But have you had any experience with using any other imaging modality? And what else are you guys doing for imaging the tricuspid?
Yeah, so, you know, great case is always by Bridge. He always shows phenomenal cases. I think it highlights a couple of important things, this case, though, and I think you saw it. I think you mentioned the one about imaging, how important imaging is, and we sometimes will turn down a case for tricuspid clipping, or often if we can't get good imaging before the procedure, right? So on the screening, if you can't really see a good, what you saw there, the inflow-outflow view with a biplane plus a good transgastric, we may turn it down. So I think that's important. You also saw some of the challenges Bridge was having in that case, because the ability to go coaxial, that often at times he was biased, you know, either towards anterior, not towards septal. And Bridge, I assume you did this with the off-label use of the commercial system. Yes. Because now with the TriClip system, there's an extra knob, okay? Because the biggest challenge we have when we do it off-label with the mitral system is hugging the septum and not getting good coaxiality. And so now with the new TriClip system, you have an extra knob that allows you to move off the septum and to be coaxial in a better way. So I think that's important. I think the last thing that's also important with the imaging that we've learned, or second last, is the fact that we didn't realize how often these patients can have quadricuspid valves. So it's actually only tricuspid, probably in about 50 to 60% of cases, but in up to 40% of cases, it could be quadricuspid. And then it now starts becoming even more challenging, right? When you have two septal leaflets or two posterior leaflets, trying to join those together becomes challenging. And then as far as ICE, we've had a lot of experience with Nuvera and help them develop the catheter. The imaging is really incredible. There's, the human experience is mostly in LAA closures and ASD closures, but in their preclinical experience, we did a number of, I'm going to be vague, edge-to-edge repair devices and valves using ICE. And the imaging is incredible because you can really, you're right there by the leaflets, you can see leaflet insertion, but more importantly, you can use X-plane, right? And 3D MPRs. The one thing we didn't speak about, and I didn't see, not everybody's using, but for tricuspid, and you really need to also be able to use the 3D multiplanar reconstructions, particularly in the more challenging cases. It really helps you to understand coaxiality. It helps you to overcome some of the limitations in imaging. And it kind of highlights the last part, which is, here we are all as interventionists talking about it, but without a great imaging specialist as your partner, you're really stuck with these procedures. You really need a good partner who's really dedicated to structural heart imaging.
Beautiful. So I'm going to go ahead and move on because we have so many great cases to another technology. So I'm going to ask Brian to go ahead and share his screen and show us what he's been working on. You're muted, Brian.
Yep, sorry, let me just get going here. Okay. Eddie, can you see my presentation there?
Yes, we can. There's a way to make it. Yeah, that's what you have to do.
Okay, good, perfect. Let me go backward. So Eddie, thank you so much. It's always great to be able to come back and talk with everyone, see some old friends and everything like that from my Miami days. So I love doing this. Thank you so much for the invitation. So it's my pleasure to talk a little bit about cable valve implantation and show a case here. So I just included this slide because this is kind of our case presentations that we go through, and this is abbreviated. We have a lot more information on there normally when we're presenting our cases, but I wanted to kind of give the groups or the attendees some flavor of these cases. This particular woman, she was only 68, but she had a previous mitral valve replacement, and she also had previous radiation to her chest. So she really, right off the bat, is a very poor surgical candidate, as are the vast majority of these patients that we're evaluating for tricuspid regurgitation. She was obviously seen by her surgical colleagues who thought that she was a very poor surgical candidate. Now, in terms of her evaluation, so she had obviously severe TR, and she had kind of unfortunately, she had a pacemaker in kind of a bad spot. And with all these technologies, as Azeem had alluded to, that there really is some limitations in terms of pacemakers when we're thinking about either repair or native replacement. So that was one of the things that she was evaluated for. So because of that pacemaker lead, she unfortunately wasn't a candidate for Evoque, and because of some questionable tethering of her septal leaflet, she really wasn't a candidate for any of the other investigational repair technologies. So that's how she kind of found her way for cable valve. And for those not familiar, cable valve is actually one of the older technologies out there. And this is just some of the original work by Alexander Lawton. But you can see in panel A some hemodynamic tracings. And I think really cable valve is really relies a lot on the hemodynamics, perhaps even more than some of the other technologies that we're currently evaluating. But you can see right there the tracings in the right atrium and the IVC. And what essentially has happened is when you put a valve in the IVC, you still have the ventricularization right atrial pressure, but if you look at the IVC pressure waveform, you don't see that large V wave as you normally do. In panel B, you can see the CT reconstruction, and again, you can see the stent and the valve that are present in the IVC, and then contrast in the right atrium, but you don't see any contrast going down into the IVC. So that is really the concept behind this, is by reducing that V wave that goes down into the hepatic veins and to the lower extremities, to really kind of help with a lot of this volume overload that all these patients are suffering from. This is just some initial data. Really, all the data from cable valve is from registries, and so these are two registries. The one on the left is from the U.S. Cable Valve Registry, and the one on the right is from European registries. And so consistently, you can see in follow-up that patients are having some improvement in the NYHA functional classification. Again, a large part of this is because you are able to decongest these patients. So this is kind of the standard analysis that we look at when we're thinking about doing cable valve. So the first thing we look for is what is the distance from the superiormost hepatic vein to the RA-IVC junction. So what we want to ideally do is fit as much of the valve in the IVC as you can, just to avoid having a lot of hardware in the right atrium. So in this patient, we had about 7.4 millimeters, which we felt was an acceptable distance. The next distance that we look for are the diameter of the IVC at both the RA cava junction and at the level of the superiormost hepatic vein. Again, you want to create the seal for this at the superiormost hepatic vein to help with a lot of the volume overload. So this was the diameter at the RA IVC junction. This was the diameter at the first hepatic vein. So this was really kind of right within the boundaries of what we consider doing in terms of cable valve. We're currently kind of limited by sizing. Again, we can only use a 29 S3 valve in these patients. So we have to kind of remember that when we're thinking about evaluating these patients, but we felt that this was an acceptable size in this particular patient. So this is kind of what we do initially. So on the screen on the left, we're doing an IVC cablegram, and that kind of allows us to see the landscape of where the hepatic veins are, where the right RA-IVC junction is. On the left, it's an AP view, and then on the right, we've done kind of a coplanar view. And so we have some radiopaque tape there present on the right, and we felt right around 60 millimeters on that tape is where we kind of want to land the valve. Again, that's right above that one vein on the right there, and it keeps as much of the valve in the IVC as possible. The hemodynamics and then obviously the imaging, as in many of these cases, is really important. So this is just kind of what the hepatic veins look like at baseline. So on the left here, you can see really, and unfortunately just stopped playing, but you can see this the kind of the bicolor flow, both the red and the blue flow, showing this hepatic vein reversal. And on the right there, you can see the echo Doppler, which demonstrates the reversal of the hepatic veins. So that's actually what we want to see. When we don't see this reversal, it's mostly because the patients have such a large right atrium and they may not necessarily have reverse cable flow. For cable valve, you need reverse cable flow to have that benefit in these patients. So if we don't see this reversal, then we really, I would really be hesitant to treat these patients, because this is that's a particular patient. You may want to look at one of the other technologies specifically. So this is kind of how we do it here currently. So on the left screen here, I've got, we have a wire in the IVC, and I have an IVUS there, which is just confirming around 60 millimeters is where we're going to be landing. And then when we do this, we need to create a landing zone. So the first thing we do is we deploy these self-expanding stents, these Cook Z stents. So you can see we have a balloon from the top, and it's blocking the stent to make sure it doesn't jump up too much. And then we've kind of deployed the stent there, and you can see we keep the stent in about the same spot. So now what we're doing here is we're just, we actually use a 26 Cook sheath here, and that allows us to then navigate beyond the Z stents in order to deploy our valve. So that's kind of what we're doing right there. And now what we've essentially done is we've deployed the valve, and there you can see we've aimed it right about the same spot. And you can see that it looks like there might still be some flow down into the IVC, but it's certainly improved from what it was at baseline. And this is really, again, where we rely on our imager. So this is what things look like with 3D here. And you can, and as again, I want to just highlight the importance of imaging here. And you can see on the image on the left that you can see the valve leaflets opening and closing very nicely there, with really no leak whatsoever through the valve. And then this 3D view here on the right, you can see the valve leaflets opening and closing very nicely. So we were very happy with that result. And again, now if we look at the hepatic veins, before you could see the blue and the red flow, but now you just see the red flow, which means that we've improved the reversal. And on the right, you can see that hepatic vein reversal that we initially saw is now obviously much improved. So this is really kind of what we're looking for. Now the hemodynamics again are very interesting in these cases. So we really look at the tracings pre and post to help us gauge our success of the procedures. So here you can see the right atrial tracing and the IVC tracing at baseline. You can see that they're actually relatively similar. They're not kind of that classic large ventricularization that you see in a lot of these patients. But then after the implantation of the valve, you see something a little bit different. So now as before, you didn't see the big V wave, but now in the RV tracing, you can really see that ventricularization. And so what that suggests is that flow that was going down into the IVC has now been redirected up into the right atrium into the SVC. And if you look at the tracing on the right, again, you can see that large V wave, and this is simultaneous RA-IVC tracings. You can see that large V wave that's present in the right atrium with a slight reduction in the IVC pressure there, but importantly, no large V wave down into the IVC. So these are really kind of the hemodynamic results that we're looking for in these particular cases, and suggest that we had a pretty good implantation. So now, the one thing that is really been lacking in CAVI over the past seven years is an investment by industry. We've really been using a lot of these off-label devices to try to do this procedure and help patients. But just recently, within the last couple of years, we're starting to see some more investment now. So specifically the Trillium device, which essentially creates a skirt into the IVC and then allows and then has these valves which allow the venous flow to come back, and then the Trick valve, which is both SVC and IVC implantation to help improve the venous backflow in these patients. So so this certainly is a therapy that I think has promise. Again, it's another tool in the toolbox. I think one thing that we certainly noticed in our center is that very rarely do we see a patient that's a perfect candidate for multiple therapies. It really is one candidate that's probably a pretty good candidate for, or a patient that's a pretty good candidate for one, but really isn't a good candidate for the other ones. And so that's why it really is important to have a lot of different ways to be able to offer therapies to these patients as we continue to move forward. So with that, I want to thank everyone for the opportunity to present, and would love to answer any questions if I could.
Wonderful work, and I know you've been sticking with this for a while now through 2 medical centers. But your final slide it was really a good introduction to what Fabio is going to be talking about, and I'd like to, why don't we discuss both of these technologies together as after we finish this. The other thing, Fabio, that you may want to tell us at the end of your presentation is a little bit just your early experience with the posterior leaflet augmentation in the mitral valve. Okay.
Yeah, excellent.
Yes.
So let me share the screen. So Eddie, thank you very much again for having me in this fantastic meeting. Tonight I have a TR case, a challenging case. I think it's a very interesting case, but I wanted to start showing this picture, showing that this was Miami Valves 2019. And I really miss Miami and miss my friends, the times where we could sit together without masks. So hopefully we'll be together again very soon, right?
Wonderful,
So,
yes.
Yeah, let's see the case. So this is a 79-year-old female with hypertension, diabetes, chronic kidney disease, AF, recurrent GI bleeding, and she had COVID last June, and her past medical history. She had a mitral valve repair in 1976, another mitral valve repair with LAA surgical exclusion in 1986, 10 years later. And in 2014, she had a dual chamber pacemaker implanted. This is the picture of the patient, large ascites, severe right-sided heart failure over the last 3 years, large ascites, as you can see in this picture, and she presented with class 2 symptoms of heart failure. Medications, she was taking high doses of diuretics, sildenafil, beta blockers, calcium channel blockers, and she was, even though she was very, very symptomatic, as you're going to see, multiple hospital admissions to do paracentesis. Her risk scores, the STS was around 11. The EURI score was 18. So this is some images. You see here the dilated right ventricle, the pacemaker lead. We would love to have Bridge here to have beautiful images of this tricuspid valve. You can see here torrential TR, and still we had the right ventricle of a good function, the taps of 20, dilated right ventricle, very large right atrium, with a volume of 90. And the tricuspid valve is a massive TR, phenatocontract of 10, and this was, the etiology was functional, of course, because of dilated right atrium and right ventricle, and as we discussed it before, because of the pacemaker lead. So it's the left heart, a very large left atrium due to the mitral disease that she had before, systolic pulmonary pressure of 62, ejection fraction of the left ventricle was 57, mild aortic stenosis, and this patient had the surgery of the mitral valve, the annular ring, a mean gradient of 3, area of 1.6 with a mild regurg. So the patient had a severe right-sided heart failure, large ascites, worsening chronic kidney disease due to a lot of diuretics. And we decided to go ahead and do the tric valve implantation. I will take advantage of Brian's presentation. But Eddie, if you want to stop here and see if other options that this patient could have, other devices, tric clip, and
yeah, that would be good. So that's a good idea. So Azeem, you looked at this, and Bridge, what do you think you could offer this patient if you didn't offer the bicable?
Yeah, pretty challenging case, you know. So I think not a great candidate for edge to edge, and I say that because the gaps look really large. And if you want edge to edge, you know, to work, you need gaps under a centimeter. But the smaller the gap, the easier the procedure. So you get a gap 6 to 8. Those are nice cases to do. So that's the one thing that would worry me. I see the lead right in the center, but also I'm worried about the RV function in this patient. I mean, this is a patient where with a valve at the tricuspid, I would be concerned how this patient's going to do, because we're just going to switch off the TR. And we learned from the Navigate data that, you know, some of these patients, they do very poorly, and you can't predict it always, right? Even some with the RV functions look only mildly reduced. You put in a valve and you take away that the ability for the RV to depressurize, essentially, these patients go into acute RV failure and die. So I'd be very worried in this patient about putting a valve in the tricuspid and how the RV would do. So, I mean, I think it goes back to what I said, you know, when you look at the algorithm, these patients who are more advanced, this is a patient with ascites, you know, liver, hepatic and renal dysfunction. This is a great patient for either a spacer type device or for cable valve implantation.
So I would agree with Azeem, you know, and I think one of the biggest issues that we are having as we are rolling out tricuspid therapies is, in the days gone by, we would look at TR and say, well, looks like moderate to severe, and really not pay too much attention to it because there was not much we could do. And as we know from contemporary surgical literature, mortality for surgical tricuspid valve operations is 10% in the best of situations. So when is the last time we sent somebody for an operation where we knew there was a 10% chance of dying? And that too, when everybody thinks, well, tricuspid valve is the forgotten valve. So we cannot forget that when we go ahead and replace these valves, even though we are doing them percutaneously, there is going to be a price to be paid, and a lot of attention has to be paid to the right side function. And this is a perfect example as to where somebody has a knee-jerk reflex and implants a valve and is going to be looking at a lot of trouble.
You know, and one last thing I would say, Eddie, you know, it goes to what Brian said earlier. When you start doing tricuspid and you tell your referrals and the rest of your institution or the other centers who send you cases that you're doing tricuspid, the first cases they all send you are cases like this. They send you the patient who's no longer responding to diuretics and who has ascites, right? And so it's so important, as Brian said, is if you think about you want to do tricuspid, think about building a tricuspid program, right? And that means you in the future going to have to offer a whole lot of different technologies. There isn't one device for the tricuspid. They never is great, and they never will be.
Yeah.
And that's
one of the things that I think is a very important point that Bridge made also is the impedance mismatch or the not being able to unload the ventricle line, and maybe the devices like the CAVI might be more appropriate in a case like this, and also the TriClip perhaps. But maybe you don't want two valves. Maybe you just want one valve. Let that right atrium become a conduit or a reservoir instead of just stopping it. Brian, you were saying?
Yeah, Eddie, you know, this is very reminiscent of when we first, you know, when we were doing TAVR in the very early days in Miami, is that, you know, when we started, we had to treat these terribly sick patients coming in shock because, you know, they had been in the community forever with no options. And that really is kind of what we're seeing now with tricuspid. Now that people are becoming aware of it, they're having these patients that they've been, you know, using diuretics for 2 or 3 years, and they come in just really sick and really decompensated. And the issue is that, you know, the longer that you sit on TR, everything just becomes too big. So, you know, you can't, the annulus, you know, you can't do Evoque, you can't do PASCAL, and eventually you can't do cable valve just because the dimensions become so big. So that's kind of one of the things we're struggling with right now. And I would suspect that as we get more into this, that we'll start to see these patients, you know, we'll get these patients earlier. But so again, that's why it really is important to have a couple of different options, because the vast majority of patients that we're treating are still kind of like this. So
yeah. Okay, Fabio, let's go on.
Okay, so in Brazil, we only have the mitral clip that we could use in the tricuspid valve, but we thought it was a terrible case for us to start this experience. So we decided to go ahead and do the trick valve procedure. So the trick valve, Brian has already shown, but it's 2 different valves, one to the SVC and one to the IVC, nitinol frames, bovine pericardium, and this device, they come pre-mounted in a 24-frame sheet. So we do our CT planning, about the same as Brian showed for his case, with the difference that we also gonna treat the SVC. So we measure the SVC at the place where it crosses the right pulmonary artery, where the valve can be more stable. We also measure here the junction of the IVC and the right atrium, and we do all these measurements here. And we had a mean diameter here at the SVC of 31, so we choose the 29 valve. At this time, we only had 2 valves. Now we have even a larger device. We can treat larger cables. And the IVC, we also do the measurements and the planning, the distance between the range, the right atrial junction. And here we had a mean diameter of 38, wouldn't be treatable by a sapien as Brian's case, because it's a much larger IVC. So we decided to go ahead with the 35 device here. This is the procedure. As I told you, this is a pre-mounted device, self-expanding. We put it there, retrieve the delivery catheter, and we try to put this belly at the side of the crossing with the right pulmonary artery. So we leave a catheter in the right pulmonary artery, you can see here, and the belly stays at this point. So this is the retrieval of the catheter, the SVC valve already deployed. Then we go to the inferior cava. See here, we leave a pigtail catheter there as a landmark for our implantation. Of course, we don't want to occlude the hepatic vein. So positioning here is very, very important. We have to do it very slowly because the valve here tends to move a lot. So we do a very, very slow deployment of the device. Here you can see, guided by echo, it's easy to see the position of the valve. And then the final result with the two valves implanted, and you see no regurg to the SVC and to the IVC. This is the echo showing the leaflets of the device in the SVC and the IVC. I'm going to skip this slide in the interest of time. Just telling you that we are starting soon a 20 patient study here in São Paulo with this device. And this is the follow-up of the patient. I don't know if you can see the images on the right. So no ascites, no edema. The patient 30-day follow-up with she's on warfarin, what is recommended for this device. We reduced it a lot, diuretics. She had a minor ascites and renal function, creatinine went from 1.8 to 1.2. So much better, probably because we could reduce diuretics. Now this patient has a 10-month follow-up, stable renal function, minor ascites. She never came back to the hospital to do paracentesis again. And she only had 2 hospital admissions due to GI bleeding. So this is the case, Eddie. I'm happy to answer any question that you may have. Thank you. Thank you again.
Also a wonderful case. Couple of questions. One is, first of all, the pacer wires are not a problem for the IVC. For the SVC stent, right? You can get around them. And the other thing I was going to ask you is what happens, and I actually wanted Brian to comment on that too, but what happens to the right atrial size when you continue to have severe tricuspid regurgitation but no longer can vent it? Does that right atrium become huge? And for Brian, how well are the regurgitation tolerated in the superior vena cava in these patients that we basically plug up the regurgitation into the IVC?
Yeah, that was kind of one of our concerns when we first started doing it. Is, are you going to get kind of an SVC syndrome when you change the blood flow? And we really don't see it that much. There's at times a transient increase in RA pressure when you just do the IVC implantation. But what we found in some intermediate follow-up is that as you're able to decongest these patients, the RA pressure actually starts going down. So the eventual pressure goes down. I'd have to look to see kind of our cases so far in the Hubbard trial, what's happened with RA size. But certainly pressure itself seems to kind of normalize and come down in those cases that you really kind of get a good seal and a good result.
Fabio,
Yeah, this patient had a very small enlargement of the right atrium at 10 months. So we expected her to increase a lot the right atrium size, but we didn't see that. Maybe we'll keep following her up. But what we saw immediately was one increase in the V wave in the right atrium. Although the mean pressure went down. So we actually still don't know what is going to happen with this right atrium. This is one of the most important things that we're going to see in this study that we'll conduct here with these 20 patients.
Great. Azeem, any comments here?
Just maybe a couple. One of the, and I think Fabio kind of hinted to this, one of the challenges with doing these kind of procedures is the fact that we do it in patients who are not candidates for other procedures, right? So in these patients with wide open TR, large gaps, RV dysfunction, and often they're also patients as a result that have very big SVCs and IVCs. And I think that's why you need all these dedicated valves. And even many patients, despite having dedicated valves, can't be treated because the SVC and IVC is very large. But the other point that, I always want to be fair to different technologies, and Fabio's case highlights it, but it's also a limitation of the transcatheter valve replacement is the need for long-term anticoagulation, right? So people say to me, but these patients, 80% are in AFib already. That's
Right.
true, but they're also old, frail. They often have hepatic dysfunction, they have liver dysfunction, and they don't tolerate anticoagulation very well. So we've had a similar issue like Fabio, where, we treat the TR, now the patient has to stay on chronic anticoagulation, and they keep having GI bleeds, right?
Yeah. TMVR also. TMVR also. Yeah.
So one of the actual decision points that's becoming more and more is, when I showed that flow chart, I talked a lot about anatomy, but we also have to think about the patient, because there will be patients who may be good candidates for valves, but they can't tolerate long-term anticoagulation. And so we can't put them in a valve, we can't put a valve into them.
Great. I'm going to move on to Joseph Lamelas has joined us. Joe is the chief of cardiothoracic surgery at the University of Miami, and he's internationally known for minimally invasive approaches to valves surgically. And so he's going to be talking to us a little bit about what he's doing with the tricuspid. So Joe?
Great, thanks, Eddie. Let me share my screen here. Sorry, I joined in late, and I was seeing patients in the clinic, but I think I'm the only cardiac surgeon on this panel right now, correct?
Correct.
Yep, so I'm gonna change gears a little bit and talk to you about tricuspid valve surgery, and these are all done through a minimally invasive approach. These are my disclosures. So I'm gonna start with a case to take you through it. This is an 81-year-old female, so you can see age in and of itself is not a contraindication to surgery. Everybody thinks that because they're old, they have to have a transcatheter approach, but obviously there's different surgical options, and I'll show you this one particular case. So she was a lady with progressive dyspnea on exertion and fatigue with a low level of activity. She had significant lower extremity edema, JVD, functional class 3, and chronic atrial fibrillation. So in 2008, she underwent a mitral valve replacement and also underwent a De Vega annuloplasty. And for those cardiologists in the audience that are not familiar with this technique, this is basically a double running suture going circumferentially around the annulus, and then at the end tightening the annulus to decrease the size. This is a technique that I actually used to do it early on in my career, being in practice 31 years. This is a technique that I was taught in training, and we used it for a while, but it did not really have very good results. So she had the annuloplasty. Then in 2019, she underwent implantation of a micro leadless pacemaker. And then because of the severe TR, they performed a tricuspid valve clipping in 2019. And despite this, her symptoms continued to progress. So she was presented to me, and the only option that I could see would be, let me just go through the T. Her EF was normal. She had a normal mitral prosthetic valve with a mean gradient of 4. She had severe TR with a significant tethering of the leaflets and a significant gap between the leaflets, and severe RA and left atrial dilatation. Again, she had chronic atrial fibrillation. So this is a T showing, it's not 100% clear here, but she did have a significant tethering of the leaflets, and you can see that the clip is there bouncing around, and really didn't do much for her. And then you see the echo showing the severe TR. This is an intraoperative echo with a Swan Gans in place, showing very severe TR. I would say much more than 4+ in this particular case. So she underwent a cath, so normal coronary anatomy. The PA is 43/16 with a mean of 28. Right atrium A wave was 39, B wave 16 with a mean of 22. RV systolic pressure 40 with a diastolic pressure of 16 and a mean of 28. So the only real option that she had in this particular case would be to undergo a redo tricuspid valve replacement utilizing a mitral valve. And then in this particular case, it was a 33mm Hancock porcine mitral valve. So this is actually a very nice operation because of the fact that we go on pump with a femoral artery and femoral vein cannulation, but we do these with the heart beating. And what's nice about this is that we don't need to snare the cavas. The snaring of the cavas in a redo operation could be potentially dangerous and life-threatening, because if you go through the vena cava at any point, not so much the superior vena cava, but the inferior vena cava, it tends to dip deep into the abdomen and sometimes very, very challenging to fix. And some of these cases have to be fixed with circulatory arrest. So the nice thing about this particular operation is that if you can see that the yellow is actually the pericardium, and a lot of these elderly patients have a very thin right atrium. So what's nice about this, there's no dissection of the tissues. This is the only dissection that's performed right there. That incision that you see right in the middle. So right through the pericardium, right through the right atrium, and then we see this is the bottom cannula right here is the femoral venous cannula that we leave in place. So you can see the Swan Gans is pulled back, little yellow and white structure at around 7 o'clock. So we leave this venous cannula in, and that blood level keeps the perfusionist from complaining about air return into the pump. And this is air return on the venous side. So we're not 100% worried about it, but that little blood level that you see, what it does, it avoids air entrapment in the heart-lung machine. And then these are the sutures placed circumferential around the annulus. Obviously, we worry about the conduction system, but for the most part, this patient had a micro lead in place, so not a big deal. And if they did develop heart block post-operatively, then they would a micro lead could be implanted or a ventricular lead in the coronary sinus. And this is the Hancock mitral valve in the tricuspid position. We take the swan out. We don't pass the swan through the valve at the end of the operation. And this is the closure of the right atrium. So I'm going to take you through a little movie here to show you exactly how this is done. So this is the incision. It's about a 5-centimeter incision. And, we go into usually in the fourth intercostal space. And a female patient will always place the arm over the head. And this is a soft tissue retractor and then a rib spreader. And this is a very limited incision. That's the pericardium. See, nice and shiny attached to the atrium. So we don't touch anything. And this is basically the only incision in the heart that we perform. We fill the heart, and then with a scalpel, enter the atrium. And then I hold it shut, so we put vacuum assistance on the pump, and we suck out all the blood in the right atrium. So once the blood is evacuated, then I use a pot scissor to open the atrium superiorly and inferiorly. Try to stay away from the inferior vena cava inferiorly so it helps the closure at the end. So you can see this looks like there's a significant amount of blood. It's not as bad as it looks, but you have to learn how to operate underwater, for lack of better words. And then this is a suture that's placed on the top lip of the atrium to hold it out of place. So you can see a blue suture, and that's the Vega annul. You'll see it now. That's the Vega annuloplasty suture that ripped apart. And you'll see the clip bouncing around on the left side. That's on the see it, there you go. That's on the interleaflet of the tricuspid valve. And that's removed. Obviously that has to be taken. Sometimes we take some of the cords. And then these are all of the annular sutures that are placed. We incorporate the leaflets and we don't resect any of the papillary muscles of the leaflets. Like sometimes we do in mitral surgery, we may resect the anterior leaflet, but we always leave the posterior leaflet intact. On the tricuspid valve, the tricuspid valve really does not have a fibrous annulus at all. The mitral has it in certain areas of the annulus, but the tricuspid annulus is completely muscular. So these are the sutures with care is taken right at this point right here, because that's where you could hit the conduction system, right? That's the in the region of the triangle of Koch. So now this is the sizer that we use to measure the size. This is, for the most part, these are very big valves. And these are 30, this is a 33. And most of the tricuspid replacements I've performed are these very big valves. And what's nice about this, if this patient ever needed a valve in valve, I mean, you guys could do it very easily, because it's you know, you just pass the valve through the vein, and you see we have trouble pushing the valve in through the incision. And then you could easily access the right heart. And I'd like to say for you guys, this is a slam dunk valve in valve procedure if it ever needs to be done. And I've had a couple over the years that have had that done. And this is a knot tire. We used to tie the knots, and usually I just tie 5 knots for each suture. And then you see you have to learn how to tie underwater as well. I mean, you usually get a feel of it, of how tight it is. And then that's the valve at the completion of the operation. And then we take the atrial lift blade out. That actually supports the atrium to allow visualization of the valve. And then what's nice about it, you can see there's the venous cannula in there. There's 2 other pump suctions that I've been using to evacuate the blood. And in this particular case, what I'm doing is I'm actually using the pericardium itself, because that atrium is so thin that closure, including the pericardium, is very nice, because it gives another layer of support to the tissues. And then, you know, again, this is done with a beating heart. We're on bypass, but the heart's beating. What that means is that the left side of the heart is empty. It's not drained, but it's empty. And then now you can see a nice closure of the right atrium. And then we put a couple of chest tubes in. This is a Blake tube, and then we put a straight tube and remove the soft tissue retractor, rib spreader, and then we close the patient. So this patient had surgery on 12/18, 1 day in the ICU, and she was discharged on postoperative day number 4. So it's an excellent little operation for somebody that has significantly tethered leaflets, in which a repair is not possible. These are all done under direct vision, and like I mentioned before, femoral artery and femoral venous cannulation. We don't do this right internal jugular cannulation. We don't do bicable cannulation. I don't feel that it's necessary. Some of the robotic guys do this, but with this technique, it's not necessary. It's a 5 centimeter incision, usually corresponding to the 4th intercostal space, using a soft tissue retractor rib spreader. And when we do mitral surgery, tricuspid valve surgery is performed very often as well. This is usually the exposure we get. This is the right atrium. You can see to the right at around 7 o'clock is the superior vena cava. The aorta is to the top of the screen. And then mitral surgery on primary cases, we'll clamp the aorta and then deliver 1 dose of an extended effect cardioplegia. So usually with 1 dose of cardioplegia, lets us work during the entire case. It limits redosing. This is the visualization of the mitral valve. And basically it's I think someone, it sounds like I'm getting a lot of feedback here, but we get direct line visualization of the mitral valve, where essentially any type of mitral valve repair could be performed. And then for the most part, if we do snare the cavas, this is the technique we use. We'll pull the venous cannula back, snare both cavas, open the right atrium, as you'll see here in a second. And then directly through the incision, we'll place a pump suction that comes in through a separate incision. And then that's snared, and it decreases any type of venous return coming from superior and inferior vena cava. And then for tricuspid valve repair, after we do the mitral valve, this is essentially very similar to what you saw before. This is the visualization of the tricuspid valve. And basically the suture placement starts at the mid portion of the septal leaflet, and it ends up at about 10 o'clock on the annulus. And then this is a typical tricuspid annuloplasty band. They're mostly on the rigid side. You see that little gap. That gap's there because that's where we try not to place sutures to avoid hitting the conduction system. And then at the end of the operation, I'll push the swan back through the tricuspid repair. This is interesting here because if you look to the right, you see a blue cable, and that's a pacemaker lead. So if anybody has an indwelling pacemaker, for the most part, not always, but for the most part, if it's a replacement, that lead will be placed outside of the replacement, and that patient can never have that lead removed. but occasionally we will put the lead through the leaflets itself, and I'll show you a short video. This is a 1-minute video. This is a tricuspid valve repair. This is after the mitral is done. You can see the patient has a pacer lead in place, and the suture started at, again, the mid portion of the septal leaflet. And it usually takes about 10 sutures around the annulus. And then that silver cable, that's the lead, that's the ventricular lead. And in this particular patient, I'll decide to leave the lead through the leaflets because it was not, sometimes the leads impinge the leaflets themselves, and they actually fuse into the leaflets. And that's why the patient has severe TR. So in some of those cases, we either detach the leaflet and place it through one of the commissures and suture it outside of the tricuspid annuloplasty band. And you can see this is a 28 milli. For the most part, we'll use either 26 or 28 on every patient. Sometimes I'll use a 30, but that would be with a massively dilated tricuspid annulus. But 26, 28 millimeter rings, or usually bands, usually take care of it. In this particular case, you can see that because the lead was not fused to any of the leaflets, I'm going to leave it through the leaflets. And usually with this particular approach, you won't have any type of tricuspid regurgitation. And then see the lead was not even attached, and I pushed the swan back in. And what's interesting, most of these leads do develop a clot formation. Perfect, thank you.
You know, wonderful creative surgery, and makes us wonder whether the mortality data we quote with tricuspid valve is not overstated, because you know, this minimally invasive approach, going through the pericardium, beating heart, you would think that it would be much more better tolerated than our old approaches for tricuspid surgery. Do you have any data on your series on tricuspid, Joe?
Yeah, we've, you know, the tricuspid surgeries in general, I mean, historically have had a 20-30% mortality rate, but that's, you know, I would say those are mainly with the sternotomy cases, and we've had excellent results with the minimally invasive approaches because, you know, we're not violating the sternum. Some of these patients have severe pulmonary hypertension, and, you know, anytime we violate the sternum and open the chest, I mean, sometimes it's hard to close the chest on these patients with big hearts and very dilated right atriums and pulmonary arteries. So the patients tend to do better. I mean, obviously, you know, this operation, like anything we do on a daily basis, requires experience, and the more you do, the better you get at it. I mean, there's no ischemic time in these cases at all. I mean, there's zero ischemic time. There's a pump run, but if you're comfortable, I mean, obviously these patients, you could expedite the operation quite quickly, and they do very well. You see, it was a 4-day post-op stay. May sound like a lot, but for an 81-year-old lady with multiple risk factors, I think it's pretty good. And in these particular cases, we've had excellent results.
Azeem, could you have done a transcatheter tricuspid valve with a micra in place? Because now we're throwing these micras in left and right, and the sequela of the micras are still not clear to me.
Yeah,
but, I just wonder.
Yeah, it's a good question. Depending on the valve, yes. Right. So, you know, there's some, I didn't show all the valves that are becoming available. For example, there's a new valve that we both know very well called VDyne that's currently under testing and will start first in man, where you don't have to go all the way into the ventricle with the delivery system. You actually, you know, have a tab that goes into the RVOT and then push the valve down. For example, could easily be put in with a micra there without interfering with the micra. Probably Evoque 2, because you really keep the valve very high up when you opening it up to grab the leaflets. You don't want to be low. Could potentially be done with a micra, and I think actually has been done with a micra in place. You know, in this case, I'm great. You know, I'm glad there's great surgeons out there like Joe who can do this kind of surgery, because this really is impactful. You know, if you can't do the surgery, this patient potentially could have gotten a valve because you saw the clip was detached. It was only attached to the anterior leaflet. which kind of highlights a little bit some of the limitations of doing edge-to-edge repair in tricuspid. We still don't know what the SLDA rate is, Eddie. It may be higher than mitral, especially in this early stage. The tricuspid leaflets are different. And the other thing we learned is, I only saw one clip there, is we hardly ever put just one clip anymore on the tricuspid. We've realized you need multiple clips to get a better outcome. I'm not trying to say, this wasn't the right thing to do. Clearly, this patient is going to have a great outcome. But the last thing I would say is also, I'm delighted to know, this patient did well, but we need more data out there from our cardiac surgery colleagues, right? Because the data we have is the National In-Sample Database data that shows this 10% mortality with surgery for tricuspid. Yet in select centers like yourself, in Baylor, they showed me their data. They showed their data for the last 18 months, and their mortality has been 0 with isolated tricuspid valve surgery. So
that was part of my data.
There you go.
He was at Baylor.
I was there for a couple of years.
Yeah.
So, but can I make a point there that the one thing that I see and so there's a clear subset of patients that and this one, the echo wasn't very representative, but they have significant tethering of the leaflets. There's really no coaptation. I mean, how effective is a mitral clip in a patient like that? I don't think it would help. I mean, I think that's what happened here. The leaflets are so far apart. They may have had a good result initially, but these leaflets are almost, vertical into the ventricle.
Yeah, absolutely. I think we talked about this earlier, and I showed some of the criteria, and I think you highlighted an important point that with whatever technique, patient selection and anatomical selection are really important for outcomes. And so we've learned a lot with clipping that you really need patients with minimal gaps. Potentially a 6 to 8 millimeter gap is the maximum gap you need. And you need to avoid those patients who have excessive septal leaflet tethering, because they can have poor outcomes too. But I think we do need to do better as interventionists. Just because there's now a new technique for tricuspid, it doesn't mean that we now need to apply this for everybody. I'm a strong believer in the fact that we should be pushing our referring cardiologists to refer us patients earlier. So not just we can offer them clips or valves percutaneously, but also we can offer them options like surgery earlier, because our outcomes will be better if we get patients earlier, irrespective of whether it's surgery or transcatheter techniques.
Yeah, very good point. I also wanted, Joe, last week you had made the point that when you do mitral clip surgery, after people that already had a mitral clip, that it means a mitral valve replacement. And actually, interestingly, in TCMV today, it was highlighted a study from the STS database that you're absolutely right, that's the pattern right now. And also we saw what that clipped tissue looked like in the tricuspid valve. So I think it highlights the thing that when we do clips in these type of patients, we want to make sure that they're sick enough so that eventually we could avoid, we don't have to do a mitral valve, a tricuspid valve replacement instead of a tricuspid valve repair. You want to make a comment on that?
You're asking me to make a comment?
Yes.
Oh, no, absolutely. I agree. I mean, I think, as was mentioned, we have the surgical or interventional plan has to be individualized. And I think, there's a lot of patients that I operate on that have had clips that were too high risk for surgery, and now they're having surgery. So, obviously that doesn't make sense, but I know that there's many that would have benefited from a mitral valve repair that have had a previous clip. But obviously, if you're clipping someone who's 70 years old that's functional and has, a P2 prolapse, that's easily handled with a mitral repair, and those patients have excellent long-term outcomes if the repair is good. And I'm not sure how beneficial a clip is in somebody like that, right? I understand that the higher risk patients that are definitely inoperable, but but somebody who could definitely have a repair in this day and age. I mean, they should be sent to a surgeon that has experience in mitral valve repair, and those will get excellent short and long-term outcomes.
Great. So I'm going to go on to Christian's case. Christian, you're there with me? I don't see you.
Yeah, I'm here. Can you hear me?
Okay, there you are.
I was listening to all this. Thank you for inviting me, and I'm listening to all these discussions, and this is amazing. I feel like I'm doing like a halftime show on the Super Bowl, because I'm going to go back to the mitral clip and other things, and you guys are killing it. But I think this is interesting because I was with you last week, and you guys were talking about this subject, and I think it's an important subject to talk. And let me just put my slide here. Can you see this?
Not yet. There you go.
All right, so I'm just going to talk about this topic. Can you see now?
Yes. Can you go full screen on that?
I'm having. Oh, I don't know how to do that. I have to screen.
Just,
That's the problem.
I think try that.
Let's see.
We can do it this way, but it'd be better if why don't you go to the presentation on the bottom of just go to, yeah.
I haven't, no, you don't see it there. I just have to screen. I'm sorry, man.
Okay.
Well,
there's a way to do two screen. Sergio, can you tell them how to do
that? Yes, but usually you see the bottom once you go.
Here, can you see it now?
Yeah.
Yeah.
Okay.
Excellent. So I'm just going to go to the basic. I think this was a topic that was discussed last week, and I think it's an interesting topic, at least for us that do mitral clips. So I'm going to talk about a iatrogenic heteroseptal defect, and this is a case of an 84-year-old female who actually had a TAVR in 2019 for AS, and at the time she was noted to have mild to moderate mitral regurgitation, and it was basically due to a posterior leaflet prolapse. She also had AFib and kidney disease. She was admitted to an ISA hospital with some chest pain and a worsening of heart failure, and she was she had aggressive diuresis, and an echo showed that her MR actually got worsened, and now to the severe stage. And you can see this. This is the severe MR, and I want to point out that they have this splash sign, and I have to give credit to my echocardiographers because they actually published this paper recently when they show that this is a side lobe artifact from the echo, and this is actually a very concerning factor of an eccentric severe MR, and that was published by Dr. Pressman recently. When we did DDT, we can see that there's actually a P2 prolapse with actually a P2 flail with actually a severe eccentric MR, explaining the patient presentation with a mitral valve area of 4.4. And on the next slide, whoops, sorry. On the next slide, you can see the 3D with the P2 flail segment, pretty nicely seen there. Interesting enough, she have a small PFO, not uncommon, but that was part of our thought process when we were thinking about doing a mitral clip. So, due to her age and comorbidities and having a high ST score, we decided to go for a mitral clip, which was a good option for her. We have a good septal height, and due to the presence of the PFO, we decided to do the Bailey sheath. We were thinking, the valve looks like a good length with no calcium, good LV function and LV size, and an appropriate mitral valve area. So our approach was to use a single NTW with grasping of A2P2. The procedure went pretty well. It was a little prolonged, and I'll show you the log, but basically the MR, significant improvement of the MR, and that corresponds to a significant drop on the V wave, and you can see the MR with the vena contracta here, the peace effect here, and the peace effect almost disappearing on this view, and in this view you can see a large piece on the ventricular side and almost completely gone. So it was a very successful mitral clip by every means, but as Friday 3:30, 4 p.m. case, we're done. No, we're not. We have a problem. Houston, we have a little hole now in the interatrial septum, maybe a little bigger of what you would like. And that's the subject of this presentation. And I want to hear you guys' thought on iatrogenic atrial septal defect. But it's not uncommon. I mean, it's actually it's common on this procedure, especially when you use large bore sheath across the septum, and you can see they can persist up to 50% when you do TEs at 12 months on these patients. They usually are dynamic, so they change in systole and diastole, and that's important to know because they can fool you. And they're usually not circular, they're usually tears across the interatrial septum. As I said, they can usually fool you because they're not circular, you can be fooled by the size, and it's usually very helpful to use 3D imaging to see the defect better. Finally, it's gonna run, okay. And finally, they don't have to be closed routinely. I think this was proven on the Mitral trial when they randomized patients to closure versus no closure, and they didn't see any significant difference. So they don't have to be closed routinely. So the first question that came to my mind that Friday is how did this happen? The use of large board sheath, a longer duration of procedures, and extensive movement of the sheath are predictor factors for this ASD to persist. And if you see in our next slide, you can see that it was indeed, sorry, having some delay here. So you can see that it was definitely an atrial aortic hogger. So there was definitely some movement of the transeptal sheath anteriorly. Most likely that played a significant role on the procedure. And more importantly, it was a very prolonged procedure because of that technical factor. So it was almost a 2.5 hours procedure. One of those cases when you say, oh, should we start from zero and do another transeptal? And we failed not doing that, and we paid the price for it. So the next question is, can I walk away from this? And the data is very interesting. It's not much data out there. Definitely, if the patient become hypoxic because they right to left shunt, you must close them. If the patient develops severe pulmonary hypertension acutely, most of these patients already have pulmonary hypertension, you should close them. And if there is any potential risk for paroxysmal embolism, either a permanent pacemaker or a history of DVT, you should consider closing this patient. There is a nice algorithm, which I'm presenting in the next slide. This was published by Carraro in CCI. It basically, if the patient becomes hemodynamically unstable or hypoxic, you should definitely consider closure if you really think that's the mechanism of the patient instability. In those patients that remain stable, they say you consider assessment of the size, how the right ventricle is working, and you should make individual decisions. I guess in this case, it was a big defect, so we should close it. And not only that, the patient, you can see that have a left to right shunt, but also have a right to left shunt. So I think we have enough reason to do what we did. You can see that it was a pretty nice tear of the septum, and there was almost equalization of a right and left atrial pressure. We have a nice 3D imaging reconstruction of the defect, measuring 30 millimeters in length in the longer diameter, for which a specific device will be needed. Okay. So now we decide that we have to close it. So the next question is, will you size it? Will you what size device will you use? And what device will you use? So in our case, I decided not to size it. I thought that it was a large tear. I don't want to put a sizing balloon to make it even bigger. So we decided not to size it. And we oversized it by 3 millimeters. So we use a 60 millimeter septal occluder. And thank God, before releasing this device, it prolapsed into the left atrium. And that was, I think that was the only good thing about this case is that I didn't release this because it got detached just by getting ready to release it. So we ultimately put a 20 millimeter device with complete seal of the defect, and the patient did very, very well. At 24 hours, the device still in place. The MR, I don't show it there, but it was significantly improved. And at 30 days, the patient have still doing excellent with minimal MR and no sign of any shunt across the intertechnical septum. So that's the case.
Yeah,
Do you have any concerns or questions?
Mauricio, you have any comments on?
Thanks, Eddie. It's good to see everybody there. So, I mean, we have can you hear me?
Yeah.
Yes.
Okay, so we had a similar situation the other day, but we have clear left to right, I'm sorry, right to left shunt throughout the cardiac cycle. So we decided to go ahead and close. I think there was no much question in our mind. I think that the algorithms that you presented, Christian, were very nice and very instructive and didactic. So some people have said, have mentioned that one of the benefits of the mitral clip is that you leave a shunt behind, because that relieves the LA pressure and then transmission of the high pressures to the lungs, and then patients get less dyspneic, and that's a basis for one of the devices that are being tested in clinical trials. Here at the University of Miami, we're doing the Relieve HF trial with one of these devices. So we're actually actively inserting small little shunts, and it creates a QPQS of about 1.2 in patients with significant symptoms with either systolic or diastolic heart failure. So that's my comment. I think it's a very nice case, and you showed very nicely how an ASD is done when needed after mitral clip.
Azeem?
Yeah, it's a challenging problem. There's really good data out of the Cedars-Sinai group. Seibel, when he was there with that group, published a great paper in JACC Intervention, which I would suggest you read. People interested should read, because it's the largest case series really on what you do with these shunts. And I think, learning from that paper, my own experience, I tend to close them if, obviously, I see right to left shunting. If the patient has severe TR, especially if I see the TR going towards the septum, if they have pulmonary hypertension. And then I always, when I pull out, I do exactly what you did, Christian. I make my echocardiographer look at it on 3D to make sure there's not a laceration, because this is more than just a defect, right? Usually you see a nice round defect. It's actually a laceration of the leaflet. Probably as you going down, I don't know if you noticed it during the procedure, that you often see in these cases, you suddenly lose height as you're doing your mitral clip. And that's when your transeptal sheath has pulled the septum and tore the septum, and suddenly you have less height. And you should be suspicious during your mitral clip if you lose height during the procedure suddenly, that you probably tore the septum. And when I see that kind of tear like you showed, I always close it, even if there's no right to left shunting. It's just too big a defect, I think, to leave behind. That patient's going to have issues later and problems later.
Wonderful. So I'm going to move on to the last case, because we're only 10 minutes from show time here. And Sergio is going to show us, I always like to show the limits of technology. So let's show this last case here from the University of Miami.
Sure, Dr. D. Thank you. While I'm sharing my screen, I wanted to thank Dr. Latib, the rest of the panel, and the attendees for their participation today. This is a short case, and now that we switch gears back to the mitral valve, it's a case to discuss patient selection and functional MR. So it's a 60-year-old man admitted with congestive heart failure and lower output state syndrome. He had symptoms of chronic congestive heart failure. He has history of coronary disease with an MI a year before, diabetes and atrial fibrillation. And at the time he comes to the hospital, he's actually on optimal medical therapy, including Entresto, beta blocker, mineralocorticoid antagonist. But despite that, he's admitted this time with need of IV inotropes and aggressive IV diuretics. And on the EKG, you can see he's not really quite a candidate for electrical therapies besides the optimal medical therapy he's already on. And so this is his ventricle. You can see there's significant LV systolic dysfunction with a prior LADMI. His EF is calculated at 25%, and it's dilated ventricle the left ventricular end diastolic volume is estimated to be around 300 mLs. So it's quite a dilated ventricle with very poor function. And you see the presence of significant severe MR with the ERA calculated almost around 0.4 centimeters square. And you see the regurgitant fraction to be around 40% in both views.
Yeah, a point that you haven't made here is that this echo is being done on Mirena.
Inotropes, correct. All of these studies are done on inotropes. The patient is admitted at the ICU on inotropes. And you can see the etiology of the MR, it's basically functional. You see the central coaptation with that central jet of MR. So despite aggressive diuresis for several days on the ICU, we're not able to wean him off inotropes. He's still on inotropes. You see his hemodynamics, even though initially there was some suspicion of post-capillary pulmonary hypertension on the echo. By the time we do hemodynamics, he doesn't really have severe pulmonary hypertension, but his wedge remains in the 20s. And we attempted several times to wean him off inotropes, but we're not able. So he's referred for intervention for the mitral valve. And part of the evaluation, again, we make sure he doesn't have at the time active obstructive coronary disease. You see the prior stent where he had the prior infarct, it's patent on the LAD. And then you can see on the cardiac MRI, again, quantify the amount of regurgitation. And we do see there's some scarring and fibrosis with late gadolinium enhancement on the LAD territory. So that's a prior infarct on the LAD that we confirm with MRI. So lately it's become quite common that we use this graph of Dr. Graber to put patients based on this EROA LVDV relationship to differentiate the significant outcomes, the significant difference in outcomes between these two big trials. So if we do that for this individual patient, we see that this patient really falls in this proportional severe MR field where the ventricle is kind of running the picture as opposed to the co-op type of patients where the MR it's kind of running the picture. But having said that, just wanted to put it to highlight that doing this on an individual basis is actually kind of difficult because this EROA LVDV relationship, it's very dynamic. It's not stable, depends on the ejection fraction, depends on the loading conditions. So it's kind of difficult to know if on an individual basis, this is a way to decide which patients are the ones that are gonna benefit from this therapy. So if we apply this to this patient, this is more of a mitral FR as opposed to a co-op type of patient. Even though we decided to...
Let's stop there a second and let's Bridge, you were part of co-op, and I think that Azeem, you were too, right? I'm just wondering, would this patient have made it into co-op or not?
No, would not have.
Yeah. Yeah, and the thing is that the other thing is that we're looking at things like ejection fraction when we have already a patient on a pressor or an inotrope in this case. And so it's very difficult to decide where this patient really is. I don't even think he falls into Grayburn's chart, because, you have artificially manipulated ejection fraction. You have cavities that have become smaller also because of pharmacologically mediated afterload. I mean, all these things are taking place, and it just wonder if this type of patient should be treated or not.
And based on contemporary data, the answer would be no. But having said that, we are in the business of treating people. So you cannot generalize, a randomized trial to one individual and say, okay, you're done. So the issue comes is, what do you think is the exit strategy? So anytime I plan on taking care of this patient, you always say, how am I going to get myself out of trouble? Once I implant a $30,000 device in this person, and then what is it that's going to say, okay, now you did your best, now the patient has gone on to, a higher level of care. Is this patient, an LVAD candidate? Is this patient going to be a transplant candidate? May not be for this particular person or not. Am I doing this MitraClip to make things better for the LVAD implantation? So those kinds of discussions, I think, are extremely important to have with your team, with the patient, that I'm not doing this in isolation. I'm doing this understanding that if there is going to be a miracle and you do great, so be it. But there is a good likelihood you're going to progress on to a higher level of care.
Yeah, Carlos, you have any comments here?
Yeah, no, I completely agree. I mean, I think it's hard to kind of use generalizations for these individual patients because they're very personalized, you know, and I think the presence of both RV, you know, LV and RV failure, you know, I mean, it's hard to predict, you know, which one of these patients are going to absolutely improve and which ones are not. I mean, I think that, you know, looking at inotropic dependent patients, I mean, that's a small subset of patients, and, you know, there's some small series, you know, showing that there could be some potential benefit in a small group of patients, but I think that, so you don't want to exclude them, but I think it's going to be very individualized, and you know, the team approach, like, you know, like we all kind of have kind of alluded to, is really important. You know, are there other options? Are there, you know, advanced heart failure therapies? You know, are there other, you know, alternatives? And what if they don't get better?
Yeah, I think it's very important to make the point that we use our advanced heart failure people for these type of cases all the time because of what Bridge was warning. And so they're very involved, and actually they've gotten to the point that Mauricio could tell you the same thing, that they want a mitral clip. They are such believers in the way that these patients improve, even when they're at this very end stage. A comment, Azeem, on that?
No, I think the previous comments were excellent, but I think what your last comment is so important, to work closely with the heart failure team, to have not just choosing the patient, but having an exit plan. But not much to add to the great comments so far.
Okay, great. So go ahead, Sergio.
So we decided to give it a chance, and here we are. This is our transeptal. And after, once we cross, we position a big clip, an XTRW. This is the clip across, and we're able to grasp both the middle scallop of both the anterior and posterior leaflet. And this is once we have grasped before we close the clip, and 2 seconds later after we close the clip, this is the amount of mitral regurgitation. We assess at this time, there's no significant gradient. We like the result and we release our clip. And this is the result. So this is on the left, you see before with a B wave and significantly high, around 50. And you see the significant decrease in the B wave and the amount of residual mitral regurgitation afterwards. But the important thing is that after that, 1 day later, we were able to win him off inotropes, and he's off inotropes. He goes home 3 days later, and a week later, he comes back to the clinic saying he has excellent symptomatic improvement. And this is the echocardiogram a week later.
Yeah, the ventricle still looks like hell, obviously.
Yeah.
But, you know, so I think these people, we've done quite a few of these now that are, you know, people on inotropes, and we give them a chance to see if we can get them off inotropes that way. And I think that it's really worthwhile, and even in these very advanced cases. Joe, you have any comments on that type of case? You're muted.
Yep. I'm surprised I never got to see this patient. I would have offered this patient a little bit of an alternative approach, by the way. But I mean, because this is a 60-year-old patient, I mean, this is a perfect one that I would have done a papillary muscle sling and a true size annuloplasty ring.
Oh, you can still see him. You know, he's now an outpatient, but we can have him see you.
Well, in a case like this, who's already had a clip, what I've also done is a sling and a mitral replacement.
Yeah.
You know, on these patients. Yeah,
I think that would be the case, and probably this is in the window that you could still repair the valve, because it's in the early period after the clip, which is still hasn't formed all the fibrous material. Because this guy was only done a few weeks ago. I think we're at 7 o'clock, and it's been a fantastic evening with this group. The good thing about having you in Miami is that we can keep talking till midnight, but we can't do it on Zoom. So I really appreciate everybody and for their beautiful, insightful comments, and I learned a lot, and I'm sure my audience learned a lot. So we'll see you guys February 3rd, 2022, without a mask on in Miami and a glass of wine in your hand. And
beautiful.
let me just go and share my screen 1 second here to sign off. So the next week, we continue with Miami valves, and now we're changing from structural heart disease after our first 4 lectures to a complex PCI. And we have Dr. Brulakis joining us, along with a panel that's being moderated by Mauricio Cohen and Carlos Alfonso. And the topic will be predominantly complex PCI and chronic total occlusions. And I think it's going to be a great conference. So those that are interested should attend. After the complex coronary interventions, then we'll have an evening of advanced electrophysiology and atrial fibrillation, and then a lot more on heart failure. And some of these topics will overlap. There'll be a heart failure comment, and also there'll be a seminar that actually is occurring on May 22nd. That arrow should be a little higher. It's actually happening the Saturday, May 22nd. And that's going to be on heart, lung failure, and mechanical support. And then remember, out to 2021, masks come off, and we'll see you on February 3rd to the 5th of 2020. Thank you all. Bye-bye.
Thank you. Bye.
Bye-bye.
Good night.
Good night.